I'd like to turn the floor over now to Shirisha Danareddy to give a talk on the care of newly diagnosed patients.
Thank you, Kent. Thank you for inviting me to speak today. This is obviously a very important topic and a pretty large one, but I want to hit the highlights today about what happens at a new visit and what to deal with. I just had a new patient yesterday in clinic, so this is obviously very pertinent. So the first visit, kind of an overview. I want to just discuss the natural history of HIV with the patient, and I'll go through that. Staging disease, and that helps us in terms of how advanced the disease has progressed, and to also give a talk to the patient about that, and whether prescribing prophylaxis is relevant. And then obtaining appropriate labs. Sometimes they already come to us with labs, but I'll go over the ones that are recommended by the DHHS. And then I also include a discussion about indications for treatment at the first visit. And it's often a question that patients have, and I'll go through that in some detail. And then, of course, risk assessment and risk reduction counseling. And then, of course, assessing coping and support and offer referrals. So first, the natural history, and this is a figure that a lot of you have seen before, and this is something that I often draw out for patients, depending on where they are in infection. Some people come in and it's clear that they've been positive for a long time. Other times they may come in during primary infection. So I like to go through what happens in terms of their immune system. And this is sort of an average of all comers. Of course, there's people that are non-progressors, meaning that they're fortunate enough to not have CD4 count decline over time, but that's a small percentage of people, about 5%. But most people will have progressive decline in their immunologic status. So during primary infection, what happens is you get a very high viral load, and then your virus in the body reaches set point over time, and what happens is you get a viral set point. Average is about 50,000, but some people have a much higher set point, some people have a lower set point. And then over time, what happens is a gradual CD4 count decline. And people can be asymptomatic for quite some time. And then as their CD4 counts get lower and lower, they'll develop either opportunistic infections or other constitutional symptoms. And if left untreated, the majority of people will have progressive decline to the point where they will succumb to an opportunistic infection. So this is kind of what I go over with people. One important thing that I also emphasize, because different people have different perceptions of HIV, so it's a huge spectrum. Some people come in and say, oh, it's a death sentence. I know I'm going to die from this. And other people say, oh, it's another chronic disease. It's not a big deal. People are living with it a long time. Just give me the meds. So it's a really, it's really important to find out where your patient is and what they understand about HIV. And so I always ask that question, what is your understanding of HIV? So then staging disease, this really helps us, and it's a way for different providers to also communicate this information to each other. Stage 1, and this is the CDC staging criteria here. Stage 1 is really people that are asymptomatic and have CD4 counts greater than 500, so immunologically preserved. Stage 2 is the in-between category. So your CD4 counts are not normal, but you still don't have an AIDS-defining illness. You can have other symptoms like thrush, however. And then stage 3 is what we want to avoid. We want to treat people before they get to that point. So CD4 count less than 200 or an AIDS-defining condition. And an AIDS-defining condition can happen even with higher CD4 counts. And so that's collapsed into stage 3. And then, of course, stage unknown prior to getting that information from somebody. And so stage 3 is clinical AIDS, and so that's what constitutes that. And that's important to know and tell the patient in terms of their immunologic status. So the next thing we do is, a lot of times most people, when they're referred to an HIV specialist, will already have a CD4 count. And that'll help us at the initial visit to determine if they already need prophylaxis. So here's some of the, here's the guidance in terms of what, when prophylaxis is indicated. So for pneumocystis, CD4 count less than 200 or oropharyngeal candidiasis or thrush. The reason why it's either of those is because thrush, even with higher CD4 counts, essentially relates to us that the patient has a T cell deficit, immunologic deficit. And patients with oropharyngeal candidiasis are at risk for PCP. So the common prophylaxis to use is trimethoprim sulfa. The next stage is if you're less than 100, then and you're IgG positive for toxo, which can vary depending on the population of patients that you're seeing. In our area, it's about 15 to 40% roughly, but then there are other places where someone can be from, like Mexico, where the seroprevalence is much higher. And what the prophylaxis is usually is Bactrim or trimethoprim sulfa, which you're covered if you're on that for pneumocystis, but there are some people with sulfa allergies, and so you'd have to think about alternate options like pyrimethamine. And then less than 50, we like to prophylax for disseminated MAC. Ideally, what these patients would get on is antiretroviral therapy anyway to hopefully bring up their counts above 50. In terms of labs, most people, like I said, come in with a CD4 count and viral load if they're screened at the STD clinic or other primary care setting. But we also like to obtain genotype resistance testing, and that came about in 2006 as acquired resistance was becoming more and more common, on the order of about 14% nationally. And so it really does impact our treatment decisions and to know what that baseline genotype is. And then, of course, latent TB, screening for latent TB or active TB. We actually just had a case where a person was asymptomatic in clinic and who had a positive interferon gamma release assay, which is the IGRA or quantiferon, and went on to get a chest x-ray, which was abnormal, and actually had sputum positive for TB. So really important to screen our patients. TB is much, much, much more common in HIV positive individuals. And then, of course, baseline kidney function, liver function, hepatitis serologies. We have Dr. Scott here in the audience who is a big advocate of that since he's treats hepatitis. And we do see a lot of patients who are co-infected with either hepatitis C or B. And then a urinalysis, a lipid panel. These are recommendations by the DHHS. And then toxo IgG, G6PD, these are sort of depending on where their immunologic status is or what medications you might be using as you'd want to avoid dapsone, for instance, in someone who has G6PD deficiency. And then HLA B5701 testing, this is specifically if you're considering abacavir in a regimen, as patients with who are positive for HLA B5701 have a much higher likelihood of having hypersensitivity to that drug. And then in terms of indications for treatment, these are the guidelines. The most recent iteration came out in January of last year. We're probably going to get a new version out in a few months. And basically what happens over time, like I mentioned, is progressive CD4 count decline. And it used to be that we would wait to treat people until they had CD4 count decline because the risks of the medications and the side effects of the medications outweighed the benefits, it was thought. But we have a lot more newer data that suggests that morbidity and mortality is improved with earlier treatment. So treating with CD4 counts less than 500. And that came about in terms of the recommendations in 2009. At that point, it was also felt to be optional to treat for even higher CD4 counts. So really the goals of treatment are to suppress viremia, to reduce the morbidity, prolong survival, improve quality of life, and restore and preserve immune function, as well as to prevent transmission. And like I mentioned, there was a debate about when to start. In terms of what tipped it over to treating earlier is that there are easier regimens that are more effective. So people can take a 1 pill once a day regimen. There are actually now 2 1 pill once a day regimens that are available. It's much more tolerated. There seems to be better immune recovery when you start earlier. So the higher you start, the higher you're going to be. Lower rates of resistance and more treatment options. Even if you fail a first regimen now, there's other options that are available. And then, of course, the decreasing transmission and the mortality benefit, like I mentioned. In terms of why people delay, obviously there's a potential for drug toxicity. There's not a randomized control trial supporting earlier treatment, and I don't think there is going to be at this point. It's a hard study to do because more and more people are treating earlier, and the recommendations already support treating earlier. Cost is a big issue, especially with declining funds to ADAP programs across the country. And then in terms of negative impact on the quality of life, and that really gets at the side effects and daily pill burden of patients. And so it's really a decision that we make, but more and more we're emphasizing earlier treatment in practice. And here are the guidelines that I went through in terms of CD4 count, and that's when you're asymptomatic. If you're a symptomatic individual, of course we want to treat. If you've had an AIDS-defining illness or even B symptoms, we want to treat you to make you feel better. Pregnant women, of course, the issue of transmission. There has been a while ago with AZT now a strong study showing a decrease in transmission to a child with treating the pregnant woman. The issue of higher viral load, that's a more recent issue, a more recent recommendation, I would say, than the past, because we wouldn't use viral load to make that decision. Although there is some data from the MAX cohort that shows that higher viremia is associated with a rapid CD4 count decline, which is the next indication. Active Hep B or Hep C infection also, and risk for cardiovascular disease. There's more and more data suggesting that ongoing viremia and systemic inflammation lead to cardiovascular disease, as well as to increased risk of malignancy in HIV. HIV-associated nephropathy, which is felt to be virally mediated, and suppressing the virus can actually improve renal function. Symptomatic primary infection, that's an interesting issue. There's a lot of debate about treating primary infection. And then high risk secondary for secondary HIV transmission. So if you have a partner that's negative and you want to keep that person negative, or if you're a person that has a lot of unprotected intercourse with multiple individuals, then you might want to start on therapy to prevent transmission to others. And I'll just say that these are the IAS USA guidelines. The DHHS guidelines are a little bit different than this. And then lastly, what I like to go over is screening for risk reduction. So at the first visit, you're not likely going to start therapy. You kind of set it up and talk to them about it and see if they're willing and ready. But there are other risk factors that need to be addressed and that can reduce their risk of transmission to others and also make them better candidates for treatment and improve their adherence. One is mental health screening. If they have uncontrolled psychiatric illness, they're not going to likely take their meds regularly. So you want to assess for that. Same thing with substance abuse. And then, of course, talk about sexual risk behavior. And that's a given for every visit, I would say, to talk about sexual risk behavior. And then, of course, if you can't offer all the support in that 15-minute visit or 30-minute visit for this, you want to make the appropriate referrals to social work or mental health or whatever else you may need.